something that that only one minister should be looking at, only a certain set of ministers. It's like having a risk officer or a risk minister. Everyone should be assessing and managing their own risks. Everyone should be following the public sector equality duty. So from that perspective, it's not fragmented. And the reason why we have an equalities minister in the Lords is because we need someone who can respond to those questions in the Lords and just help out. So that was a supporting role rather than evidence of fragmentation.
So you've referred to the Government Equalities Office. Historically, there have been a number of offices or units within government dealing with separate sectoral issues. So there was a race disparity unit, a disability unit, I think, and a government equalities unit. And all that was brought together in the single equality hub, of which we'll hear more.
Yes.
I think, and is that the bringing together of those disparate elements of which you speak at the beginning of COVID, I think in September 2020?
Yes. That was a decision that was made by Liz Truss, and we talked about it and agreed that a hub and spoke model was the best way to deliver across the board. A lot of departments didn't really want to think about equality and would rather someone else just had it so that they could just focus on delivering. And you will notice that all of us had roles in other departments, so that we were not solely focused on equality. This is something that's been challenged several times. I remember being asked about this in the Women in Equalities Select Committee. I do think that that model works. And what it means is that it forces a way of thinking into departments. Being in the Treasury at the same time as I was Equalities Minister was actually quite helpful, because I could use some of the Treasury levers, which I would not have had if I had just been in a totally separate department where they probably would have been less interested in my work because they were prioritizing theirs. And that has meant that the way that you need to think about equality, the best practice, lessons learned, ends up being seeded across departments because you have ministers wearing both hats.
So one can readily see the advantage of having a minister concerned with equalities amongst the portfolio for which your area is concerned with. And the embedding or the embedment of best practice and lessons learned in each department. But by having a number of ministers and not having a single higher level minister, a Secretary of State, for example, concerned with equalities, did that mean that politically the whole area of equalities was able to, well, had less political heft or clout, weight at the highest level of government?
No, I don't think so. And to be honest, a lot of these things end up being determined by the personality of the person who is in the role. If you have someone who is perhaps more extrovert is not the right word, but who perhaps has a real passion for these things and is able to make the case and make the argument in government, they will have more salience than perhaps someone who is less interested in it and who just happens to have been given the role. The political skill of the person who is inhabiting the role makes a difference, but the point you're making about whether this means people aren't focused on equalities across the board is a good one. Looking at it within the pandemic perspective is easier than when there is no pandemic. The roles were not created just for the pandemic. It just happened to be what was there at the time. But equalities covers everything. If you look at the Equality Act, across the board, protected characteristics, it can be everything from how economic policy affects elderly people or young people, how education policy is affecting, people of a particular religious background. It covers every single thing. And so the political salience often is determined by what is in the news at a particular point in time. COVID was in the news. The disproportionate impact on ethnic minority communities was in the news. So equality suddenly took on a lot more work and had a lot more attention. I was in the role at the same time and happened to have very strong views about how things should be done, happened to have a lot of personal experience and my own personal bias of wanting to start with evidence and data rather than what often tends to happen in politics, which is noisy campaign groups and lobbying, and whoever can get the attention of someone for political campaigns. And that, I think, influenced the approach we took with quarterly reports, for example, bringing in more scientists, and thankfully having the RDU, which was a great unit, not a delivery unit, just mainly data focused. If it had been a different person or a different type of issue, the response would have been quite different, I suspect. So it adapts.
Rather than relying on the interpersonal and political skills of an individual minister as part of this structure, would it not be better to have a single higher level government minister responsible in an overarching way for the delivery, to use that terrible expression, the delivery of inequalities, and in particular in the context of a pandemic, dealing with the impact of the pathogenic outbreak, dealing with take-up, dealing with barriers to access and so on?
I'm not sure that would have worked. We did have someone in cabinet with that responsibility. I was a junior minister at the time, but Liz Truss was in cabinet, so that would have been her job. If what you're saying is, should we have had someone who was exclusively focused on that and had nothing else, I think that the disadvantage would be they would have no levers. They would purely be in an advisory role.
Because they wouldn't be in a spending department.
No, they wouldn't be in a spending department or a delivery department. They wouldn't have levers. And this is where we need to look at the reality of what government is like, that every department has its own silo with which it's working. It's not that easy to partner up. We do try and collaborate, certainly in my experience. But collaboration often is determined by the interpersonal relationship between two ministers. Otherwise, the usual office politics we find in any organisation come in, where this is our money, it's our business, we know what we're doing, leave us alone, not invented here syndrome. So I think we need to be realistic about the likelihood of success with that model. What you want is every single Secretary of State or every single minister, whether they're in cabinet or elsewhere, understanding what it means to deliver properly when it comes to equalities across the board.
All right. Your responsibilities when you were minister were extremely wide, were they not? In the context of responding to the pandemic, your ministerial functions included all the usual work done on racial and ethnic disparities. I think you responded for the government to Dr. Sewell's Commission on Race and Ethnic Disparities.
Yes.
Dealing with the Gender Recognition Act. You sponsored the Social Mobility Commission. You were concerned with the Equality Act. So all those functions carried on during the course of the pandemic, did they not?
Yes, the Commission on Race and Ethnic Disparities actually was as a result of the pandemic. It was one of the government responses to what we saw as a lack of trust amongst communities across the board, which was highlighted during the pandemic. So that would not normally have been something that we were doing. The work of the Social Mobility Commission carried on, but it was very low priority. It did not take up that much time, and it is independent. The minister's work is really overseeing and making sure that it's running properly. So my work, thankfully, in the Treasury was not that it was not that intense, because almost all the resources were mobilized towards managing the pandemic. I filled in for other ministers who were busy, so I did have time, certainly in the Treasury, to do the things that you've outlined.
You were responsible for the production and publication of the 4 quarterly reports.
Yes.
To which we'll return in a moment. You were obviously concerned with the issue of communications with ethnic minority groups, subpopulation groups and other marginalised groups in society in the course of responding to the pandemic. You were intimately concerned with addressing problems surrounding the uptake of vaccines, dealing with mis and disinformation. You attended the COVID-0 Cabinet Committee meetings, and you presumably liaised very closely with the COVID-19 task force and other parts of government concerned in responding to the pandemic. I just want to look, I've mentioned the COVID-0 Cabinet committee meetings. Can we just have a look at a COVID-0 meeting, please, on the 25th of January 21,
Okay.
INQ 000-91823. We can see from the top of this page is the minutes of the COVID-19 Operations Committee. Your name is there on the towards the bottom of the first page.
Yes.
And if we go to page 4, we can see a long section of text from the Minister for COVID vaccine deployment. Was that Nadeem Sahari?
Yes, that should have been, I believe that's right, yes.
And what he says is, although vaccine confidence is running at an all-time high, the 15% of people who are vaccine hesitant skewed towards black, Asian and minority ethnic communities. I know the policy position of the government is we no longer use the acronym BAME, but it was being used then. Further action was necessary. Work would continue with the Secretary of State for Housing, Communities and Local Government to minimise issues across hard-to-reach groups. Again, we don't use that phrase nowadays. There were concerns with the level of anti-vaccination messaging, reference to local community champions, and then further down, concluding, he returns to the issue of welcoming colleagues' views on identifying further barriers, safety concerns, lack of access to health services, translation into different languages, and so on. Also reference to local and trusted voices. And perhaps just to finish this, if we go over the page, one more page, please, we can see a number of separate points under that general heading in that rubric, particularly data and the need to monitor effectiveness. There was no doubt, was there, on the part of government ministers and the various government bodies, that there were real issues with reducing barriers to access, increasing confidence in the vaccines, and trying to get vaccines delivered effectively, safely, speedily to all the many subpopulation groups within our population. Give us an idea, please, of the degree of willpower, the speed with which the government was onto this issue. It's obviously referred here at the highest level, and we'll see in a moment it's referred to in cabinet. But did the government, do you assess, get on top of these issues as quickly and as effectively as it could have done?
So, specifically on data.
Well, actually all of this, but data is an important part of the topic.
Data was the biggest challenge. This might be because the unit that I was overseeing, the race disparity unit, was a data unit. And so we would have been more interested perhaps in data than others. But we constantly encountered issues in just finding out what was going on. Sometimes that was because the data hadn't been collected in the first place, so there was nothing to look at. And finding out whether it had or had not been collected could also be a challenge. So you didn't know whether there was something to see and we couldn't find it, or there was nothing to see. Then there was the issue of people having data, but not wanting to share it because of the conditions that they had been given when they were collecting it in the first place, GDPR, consents, and so on. And probably a third bucket of there being an issue of trust or not wanting to collaborate with others, people wondering, why do you need this data? Don't worry about it. We can do this ourselves. We don't need you to look at it. So a level of competition, perhaps, or just suspicion about why other groups are carrying out work which perhaps some units may have felt was solely within their purview. I can't remember specifically where these other bodies were. I know some of it was in academia, a lot of it was in the NHS. Just getting information out of the NHS, I found, was the hardest thing.
Presumably there are any number of systems within government for the recording and dissemination of data. In ONS, there's obviously data there. Public Health England, AXA, as it then became, NHS England obviously has data. GPs, There were a number of observational studies, UK Reach, Open Safely, which had access to millions of records.
Yeah.
So the problem wasn't a shortage of data. Did the problem lay in its, did it lie in its production in a useful form to decision makers?
There was a shortage of data. Just because there's lots of data doesn't mean it's what you're looking for. So in terms of, if you're talking about volume, yes, there was lots of data. But I remember us trying to find out the ethnicity of people who had been dying, especially the frontline ethnic minority workers in the NHS. We didn't have that. So my first quarterly report, I think, talked about the mandatory collection of that sort of data. So there were still things missing.
So at the beginning, there was a specific problem with the recording of ethnicity data amongst patients in hospitals and also amongst those who died from COVID.
Yes, and it took a long time to get this resolved. The hoops that needed to be jumped through, I was told, because I wasn't the one carrying out the data collection, but I was told by my team that it was quite difficult, and I know eventually they got there. But you are right, across multiple systems, whether it's Open Safely, ONS, and so on, there is data. Sometimes the data that you have is it's not live, it's old. And the systems are set up to do different things. They don't necessarily use the same categorization to reference the same information. And that's understandable because these things have cropped up in different ways. They've been set up for different purposes.
We'll move forward and look at, in fact, now your final report, the fourth quarterly report dated the 1st of December, because there was much in that, wasn't there, about data, and you made a number of recommendations about how to better accumulate and publish and then rely upon data. Can we have INQ 0000897747, please? This is the final report dated December 2021. And if we could pick it up, please, at page 5. There is an overview and executive summary. This was obviously the fourth report, and so it builds upon the learning and the knowledge which has been, which was set out in the earlier reports.
Yes.
And this page is concerned with the increase in your understanding, your better understanding of the risk factors involved in the pandemic. At the bottom of the page, the most significant measure to protect ethnic minorities from the risk of COVID infection and to save lives has been the vaccination programme. And then over the page, page 6, you set out there how the government worked with national and local partners to promote vaccine uptake, and there's a number of ways set out. Thank you very much. And then if we scroll back out, there's a reference to the Community Champion Scheme in the bottom half of the page and to wider public health lessons. And then I'm afraid one more page, please. That part finishes on page 7, and then on page 8, a number of recommendations, and they're not numbered, but if we could scroll back out and go down to what is roughly recommendation 11, it'll be over the page, I think. Thank you very much. The top bullet point: relevant health departments and agencies should review and action existing requests for health data and undertake an independent strategic review of the dissemination of healthcare data and the publication of statistics and analysis. Ms. Badenoch, this fourth report was published in December 2021, so the end of 2021, at the end of the second year of the pandemic. You were calling for and making a recommendation to this effect for relevant health departments and agencies to review and action existing requests for health data and to carry out a strategic review. May we take it from the fact you were still calling for this and you were making a recommendation to this effect at the end of December 21, that by that stage the system was still not working as well as it might?
I think this was really a forward look. because there was, and I can't remember the exact name now, but there was a new Office for Health Disparities that was to be set up, and I wanted to make sure that it was starting with the knowledge which we had accrued and starting with some of those actions, and actually be able to monitor them. So the Equality Hub doing this work was always a time-limited thing. We certainly did not have the resources to monitor what every department was doing throughout. So this was a discrete project, a discrete piece of work. We've carried out recommendations, but at this point, I'm thinking, well, we're going to have to go back to our day-to-day. How do we make sure that this work carries on and people understand the lessons learned? So the hope was that that new Office for Health Disparities, I'm sorry, I genuinely can't remember the name of it now, but I know it is in existence, would be picking up this sort of work and running with it.
As it happened, the government commissioned a report into health data. It's called the Health Data Review, and it was led by Professor Kathy Sudlow. It reported in November of last year, 2024. And I wanted to ask you, and I appreciate it's not something that's you've been required to look at, but I wanted your impression. Amongst the 5 recommendations that Professor Sudlow made were these 2 recommendations: that there should be a national health data service in England for health data, and secondly, that there should be a UK-wide approach to streamline data and therefore to improve understanding by all the governments within the 4 nations of the impact of the data and what can be learned from it. Are those 2 recommendations something that you would endorse? Was it your view that something did need to be done about setting up a national data service and having a consistent aggregated approach across the United Kingdom?
Yes, with caveats. So yes, I do think some streamlining and rationalization of data sources is necessary, and also making sure that we're using the very best labels, the very best categorization, because it is confusing. You talked about the use of the term BAME. There was a plethora of labels that was being used. We never knew whether we were all talking about the same thing or not. So yes, in principle, I do think that is something that should be done. I don't know the genesis of Professor Sudlow's work, but I have come to this conclusion via separate avenues. However, there is a challenge now with how well government itself is placed to deliver this sort of system. And I remember, it's over 20 years ago now, when I was working on a project for the NHS Spine, when we were supposed to have a national health service, IT system, and it failed. Government is not necessarily great at delivering these systems. They tend to be big boondoggles for the private sector. But there are private sector companies that can deliver this. There need to be caveats around that. There is a big debate going on about how we use health data. Should we let AI into the system? Because the more data you have, the harder it is to process, and you start to require machine learning and so on. And there are many ethical concerns about allowing this data to be used by pharmaceutical, for-profit sectors and so on. I personally have no issues with that, but those things need to be considered in tandem if we are going to do this. There are a lot of risks as well, which I've seen from being in government, having security briefings about how external actors outside our country try and destabilize information systems. There would be a big risk in creating something like this. It's important that we are aware of those and have things to mitigate. But in principle, I think that this could work. How we deliver it would be the question. Make sure it could be quick and successful.
The Equality Hub, for which you were responsible, produced a report in July and August 2021 called Perceptions of the Pandemic Research, which showed high levels of distrust in the population, that there were significant numbers of people who didn't care about the pandemic, didn't have a great deal of trust in government, and believed that that they should not take up the offer of vaccination.
So what date was this? I'm just trying to make sure I'm not...
It's August 2021.
August
It's
2021,
called
right.
Perceptions of the Pandemic, and it was research carried out by the Equality Hub. It's obvious that your quarterly reports made a number of serious and considered recommendations. Your first report made 13 recommendations. There were a number of recommendations in the second report, and then in the final report, I think there were as many as 17 recommendations. The fact that the reports were worked on and then published over a considerable amount of time, from the 1st of February 21 to the end of 2021, rather suggests that the government was having difficulty getting traction in getting change brought about. Would you agree?
Yes, it was difficult, but also it was novel. We were doing things that we hadn't done before, and I think that can make things slower. Resources were also limited, not just in terms of people who knew how to do this, bodies on the ground, but also everybody was dealing with the impact of COVID as well. We weren't all in the same place. The sort of things that might happen faster if you were working in the same room, people just being at home, some people falling ill, getting COVID themselves, family impact, all of that ended up just slowing things down.
In your statement, and perhaps we could have it up on the screen, please, 492283 at page 16, you set out a number of the initiatives which your department or which the Equality Hub put into place. The setting up of vaccination centres in around 50 places of worship, bespoke programmes to increase vaccine confidence in particular communities, targeting religious events, the use of pop-ups, improving uptake amongst ethnic minority healthcare professionals, working with the BBC Asia Network World Service. I could go on. A long list of things that were done. By and large, were you successful in driving up uptake as a result of the many initiatives which were undertaken?
I think it made a difference. It certainly created improvements. The biggest benefit, I think, was the awareness raising, which meant that other people started doing these things, and that we weren't relying just on government. Government alone cannot deliver at this scale. You do need the rest of, whether it's civil society and just people using their own initiative. And I think that was the biggest difference that it made. I wouldn't say, for example, that we were able to personally touch every single ethnic minority in the country, or that every single person heard every single bit of government messaging. But the dissemination and the spread and the concepts, I remember we had certain phrases that we needed to seed. I think that those did get embedded. Some of the things were not as effective. I remember trying to use the high commissions to target diaspora groups. I never really saw any evidence that worked. They did try, but I don't think that going forwards that would have been a place that I would really spend much of an effort. We
Just
were hoping that they would
expand on that, if you'd be so kind. You spoke, I think, you met with a number of high commissioners. What, from those countries whose nationals were most at risk from COVID?
Yes, or certainly people from that ethnic origin. And what I found was that they also could not reach the groups that we struggled to reach. So they didn't have a much better access. They tended to deal with people who were, using consular services and so on. They were not the hard to reach groups. The hardest to reach groups, if I recall, were people who were dealing with perhaps a home country via personal private channels, not through the High Commission. So they didn't interact with it. They didn't need it for passport services. They just didn't know who those people were either.
All right. It's obvious from your statement that there's a distinct limit on what central government can do. You can identify the problems, you can convene meetings of people to discuss what can be done to solve those problems, and you can generically approve plans, actions, and identify broadly what needs to be done. But there are a great deal of departments and entities and bodies concerned in this field, from directors of public health, local authorities, NHS England, the JCVI and SAGE had a role as well, the DHSC, and the Office of the Chief Medical Officer. So there's a very significant number of bodies trying to deliver, to use again a terrible expression, but trying to deliver what it was central government wished them to do. Is there a way of operating this system in a more efficient way, or at least being able to understand more clearly who is actually going to be accountable for delivery, who is going to be responsible for practical measures on the ground? Or does it have to be this way?
Honestly, I'm not sure. Because when you look at some of the things that needed to be delivered, it had to be local government. There's no way the central government could do those things. You need local councils, whether it's counties or districts, who actually know and understand the communities. So I think trying to drive everything centrally will not work. And so that's why I am probably not convinced by the idea that we should just have a big central hub that knows everything and knows what it's doing. You know, I often say that we need better government, not more government. The more different bodies that exist, the harder it is to actually know who should be doing what. So there is an argument for having some streamlining. But each of those bodies, you know, JCVI, for example, was tasked with doing something specific, and they should have been collaborating. So better collaboration across the board is important. There will often be some duplication, but I mean, the list we were looking at, some of this was trial and error, that we think this might work, let's do it anyway. That it's better to do it than not do it. The feedback mechanisms for what actually works are very weak indeed. It's very hard to know what is working and what isn't. It certainly felt like that during the pandemic.
What is working on the ground?
Yes, and so there is a try everything, because some of these things will work, and it's better for us to duplicate than to miss something. And I think that was the attitude that we took. So that's why the list was so long. Not everything would have been effective, but I could see some areas that certainly were not effective, and others where we knew it was working, but exactly how or why, it was just really difficult to get good feedback.
Milady, is that a convenient moment?
So I'm sorry we have to break, Ms. Badenoch, but I promise you we will finish your evidence before lunch so you can get on with your other duties.
Thank you.
I shall return at 12:05.
Bye, guys.
never have been by my unit, and I would not have been aware of the success in terms of deployment of vaccines. My understanding was that they did do that, but it may have been only those that opened for the full 12 hours. And I don't know what the reasons for that I don't know what the reasons for that were.
From the paperwork produced by your department, it's obvious that there were also a great deal many meetings with local authority leaders, with and time spent debating how local authorities could step into the breach and ensure that public health messages were disseminated and that members of the local populations would take up the offer of a vaccine. By and large, do you think that local authorities were used enough? It's obvious that in any system of national vaccination, it has to be driven by the centre. And obviously questions of prioritisation and manufacture and delivery have to be driven by central government. Do you think local government played or was asked to play a sufficiently important role?
I think so. I wasn't in DLUC during the height of this. By the time I came into that department, a lot of this work had been done, and it wasn't strictly speaking within my policy area. But I do recall multiple meetings being had with leaders of local authorities. I think that what you've described is really more appropriate for directors of public health who work in conjunction with local authorities, the integrated care boards. Local councils have a very specific remit when it comes to health delivery. And I think that this would be giving them more to do would be quite a challenge. It's not what they're used to doing. I think it's the directors of public health and using the health mechanisms locally rather than the local authority specifically.
But aren't they the bodies who are most likely to know what the state of deprivation is locally, the degree to which vaccines were not being taken out by ethnic communities, and also what practically on the ground could be done in terms of going door to door to housebound residents and making sure that they were vaccinated? Isn't that a local authority issue?
It is, but that I think they did well. I mean, I saw what my local authority did, and I thought that they did that fairly well. But in terms of the more clinical public health aspects, I would expect the advice to be coming from the Director of Public Health, the delivery levers perhaps using local authorities. But from my understanding and my own personal experience, I thought that that was what they were doing.
How effective was the Community Champion scheme, which was something very much at the heart of your department's response?
Actually, Community Champions was a DLUC sponsored scheme. We advised, and they were already carrying out a community champion scheme. We advised on how it could be used to deliver the objectives of the work that we were doing. So we worked in partnership with them, but it was actually levelling up housing and communities responsibility. The communities departments led on community champions, and we fed in. And we gave them a lot of insight and a lot of intelligence on where to go, I think, and how to make sure that it was successful. But the delivery of it was actually in DLUC. And I think that they did do a good job. It wasn't everywhere. So community champions were specifically in those places where we thought people were hard to reach. And my understanding and the reports which we got back, which I don't have to hand, but I had a better feedback mechanism from what community champions were doing than I did on the communication angle, where we just weren't sure what was working and what wasn't.
And what is the great value of a community champion? Is it to do with being able to provide for a high-profile, trusted local figure whose messages about vaccination will be believed and accepted and can raise the profile, of course, in public health terms, of what the government's seeking to do?
Yes, that, but also they know what's going on in a way that those of us with offices in Whitehall will never know what's happening in a particular local community. They have a better understanding, better intelligence, and they are part of those communities, so they want them to be healthy and successful. They have a vested interest in seeing things work.
Mis and disinformation. Your fourth quarterly report made a number of recommendations concerning trying to, what could be done to dispel myths, reduce fear and build confidence amongst ethnic minority people. Was the further work that you identified, and it was in your first quarterly report of October 2020, was that further work done, do you know?
No, I don't know how far the work was taken. I know that there is, or certainly there was, a unit that looked at this, but it looked at misinformation and disinformation across the board, yes. And a lot of its work is very sensitive.
Could we have a look at INQ 0000089742? This is Ms. Badenoch's statement, and no, sorry, I think it's the first quarterly report, and page 62. No, I think I must have got the page reference wrong there. We'll try one more. Can we have INQ 00000897? No, I think we'll leave it there. 2 pages of the first quarterly report set out in quite significant detail the degree of prevalence of misinformation and disinformation. In terms of countering misinformation amongst ethnic minority groups, is there a limit on what central government can do?
There's always a limit on what central government can do. I think it's probably worth explaining what it is that I mean by misinformation and disinformation. People often assume that it's stuff on Twitter or X. I'm actually less worried about that sort of misinformation because it's very public and people who know can challenge it easily. So that's an open sphere. The things that really concern me are the pieces of information that are less visible. The last time I was here, I talked about WhatsApp groups, for example, family WhatsApp groups, things that government has no insight into. Even the tech companies don't really know what's being shared. It's all encrypted. And a lot of false information travels very quickly through those channels. And I don't know how we can deal with that. And it's everything from vaccines will kill you to the government is suppressing information. In fact, some of it often has lightly reputable sources who are backing it up. I remember we had some people from the BMA who genuinely believed that we were trying to stop information from getting out about what was happening with ethnic minorities. And when you see that on a public forum, you'll think, oh, well, if the doctors in the BMA think that, then it must be true. But even they were wrong. And then that starts to propagate. And the thing that government can do best is provide as much information as possible and show that we are, that we're all in it together. That was one of the reasons why I decided to take part in vaccine trials. That if people thought that the government was trying to kill them, then if the minister herself was taking part in trials, which are more risky than a fully tested vaccine, that might help with public trust. But I don't know the answer to dealing with that sort of back-channel information that's peer-to-peer and private, beyond the government supplying as much honesty and as much truth as possible, and also not attacking the people who are propagating this. So as annoyed as I was by representatives of the British Medical Association saying these things, what I didn't do was go after them, because that can actually fuel the misinformation or the conspiracy.
All right. In your final quarterly report, you made 7 recommendations, all of which I think were accepted by the then Prime Minister in full. Is that right? And I just want to focus on a handful of them. Recommendation 6, and you've just referred to the issue of clinical trials, recommended that confidence be built in future vaccination schemes by increasing ethnic minority participation in clinical trials. Was it your view at the time of the promulgation of the report that there had been insufficient diversity in clinical trials? We've had a a great deal of information and evidence about the actual figures for diversity in the clinical trials on the part of all three of the COVID-19 UK vaccines. But was it your view that certainly in the public sphere, there was a lack of confidence in vaccination, in part contributed to by a belief, rightly or wrongly, that there was a lack of diversity?
No, I think it's there's a lot of yes and no in that. I think it's more complex. So let me try and unpack this. Within ethnic minority communities, irrespective of what's happening here, there is distrust of public authority. Most ethnic minorities have come from authoritarian regimes or places where the government may actually be trying to get you, and that's why they've come here. So there is a baseline level of suspicion that is just higher than we in the UK have generally, and it builds from that. So when we're looking at the lack of trust, we've got to have that in mind, that there is a cultural aspect here that shouldn't be ignored. Do I think that it is true that ethnic minorities did not participate in vaccine trials? Yes. First of all, for that reason. Secondly, just because it just wouldn't have been. It's just harder if you were in a community that's more likely to be closed. If levels of education are lower, it's not something that you would ordinarily do. I think that that's right, but that's just personal observation. I did have clinical representatives tell me that participation was low. And if they said that, there was no reason for me to dispute that. Anecdotally, I would have expected that. And so,
that's
yes.
why you sought in your recommendation that
Yes.
participation should be increased. We've discussed data already, but I think 4 or 5 of the recommendations in the final quarterly report were about data, and they reflect what you said this morning about your concerns about the data, operation of the data systems. Did you happen to have in mind, or did you make any recommendations concerning the recording of data for disabled people, or was that outside the brief of the report?
It was outside my brief, but I think it was discussed. I can't recollect where there were issues or if there were issues. But we had to draw a boundary between what I was doing versus what Justin Tomlinson, as Minister for Disabled People, was doing. We had a team of in the Equality Hub that collaborated and worked together, but there was only so much that I could look at, and that was strictly speaking outside the remit that I'd been given.
Recommendation 17 suggested that government needed to build on community partnerships and work closely with local networks to improve understanding and gain insight into the audience being ethnic minority groups, for the purposes of future public health campaigns. And that government needed to utilise community partners to co-create content and tailor communications that resonate better. Ms. Badenoch, it's obvious that you had a great deal of communication with trusted figures, local trusted voices, local authorities, all manner of representative bodies and groups, as well as other parts of government. So what did you mean in practice when you said that community partnerships needed to be built on and there needed to be a closer working relationship? Were there not already all number of meetings and any manner of emails, roundtables, communication with everybody working in local government and also in the voluntary and charitable sector?
Yes, but that was all in the context of the pandemic. And as we were coming out of the pandemic, many of those bodies would not be convened again. So it was about leaving a system in place, not as intense as what we had right, in the middle of 2020-21, but something which could be mobilized more quickly should this sort of thing ever happen again. And actually learning some of there were many insights that were gained that were adjacent to the work that we were doing on COVID-19. And seeing that level of collaboration just producing useful information, I thought was something worthy of pursuing. But it had to be, it still has to be encouraged, but organic. Central direction, I think we'll just end up with lots of people having meetings and not really doing anything serious, and then convincing themselves that because they've had the meetings, good work has been done. We need to make sure that with these partnerships, it's genuinely outcomes, not just being in a room and having a discussion.
So at the heart of it, the relationships need to be fostered and they need to be nurtured and they need to be done so outside the particular demands of a pandemic.
Yes.
Because only when the next pandemic comes will those relationships work if they've been looked after in the meantime.
Absolutely.
Is that what you're saying? And more generally, those relationships need to be nurtured and pursued, not just in the narrower context of vaccination and the impact of a pathogenic outbreak, but generally so that they're ready to go.
Yes, and not just top down, but also bottom up as well, which I know is harder, but it tends to be more long lasting.
All right. Thank you very much indeed.
Thank you, Mr. Keith. There are just a few more questions for you, Mr. Badenoch. Mr. Thomas is over there. We'll start. Thank you.
Good morning, Miss Badenoch. Can you hear me?
Yes, I can.
Okay. Good morning. I'm representing FEMHO, the Federation of Ethnic Minority Healthcare Organisations, and I've only got a small handful of questions for you.
Okay.
Vaccines as a condition of deployment. Can I just turn to that area, please? In your witness statement, you express very real concerns about the VCOD policy, particularly its workforce implications and the disproportionate impact that it had on ethnic minorities. Do you believe your concerns were taken seriously and sufficiently addressed in the development of this policy?
Yes, I do. They were taken seriously. I recall having read the briefing notes, the meeting we had to some extent, where the concerns I raised were acknowledged, but there were many different arguments in the room about the levels of risk on carrying out the policy and not carrying out the policy. But I never felt that I was being ignored or not taken seriously.
What feedback, if any, did you receive when raising your concerns within the COVID-O committee?
I recall a discussion on the pros and cons of vaccines as a condition of deployment. I had meetings with the BAME Communities Advisory Group, where they were concerned about people leaving the workforce rather than taking a vaccine. And that would have been quite damaging for the social care settings in particular, because we needed those people to carry out the work. But there was also a concern that if people were not vaccinated, then they would be at more risk of getting COVID and also passing it to very vulnerable groups. So it was about balancing those two very serious risks and working out what the best outcome would be.
I want to be future-looking. Given the policy went ahead for health and social care workers, despite the objections that you raised, are any changes necessary to ensure that concerns of the Minister for Equality are taken into account in the future?
Well, they were taken into account, and I think this is one of the things that we just have to accept, that within the government decision-making process, different people will make different arguments, and some people will win and some will not. And that depends on the particular subject. A Secretary of State or a Prime Minister will hear all the competing views and then make a decision. And I think if your view is not the one that's taken, it doesn't mean that it hasn't been considered, because they can't agree with everybody. I think that the fact that the policy eventually didn't go through or was reversed, and the larger issues around certification in the end were not pursued via legislation, shows that it was just not going to be that workable. But even I understood the arguments that others were making about why such a policy would be necessary. I didn't agree on balance that we were in the right place. I also, even with the BAME Communities Advisory Group, didn't want us to overplay the significance of the risk there.
Madam, thank you very much.
Thank you.
Thank you very much, Mr. Thomas. Mr. Jacobs, I don't know if you can see Mr. Jacobs.
Yes, I
behind the
can.
pillar. Yep.
Good afternoon.
Hello, afternoon.
I represent Gypsies.
Are you switched on, Mr. Jacobs? I'm sorry.
Can you hear me?
Yes,
Yes,
yes, I
now.
can.
Hello, I represent Roma, Gypsies and Travellers, an act for the traveller movement instructed by Hownco. I wanted to ask you a couple of questions in relation to your statement. You cite in your evidence a number of initiatives that were taken to increase vaccine confidence in minority communities. I think you discussed these with Mr. Keith, King's Counsel, this morning. And some of these initiatives included bespoke programming to increase vaccine confidence and the use of mobile and community pop-ups. Is that right?
Yes.
And the traveller movement's position is that there were no such initiatives designed for the GRT community, Gypsy Roma Traveller community. Do you agree, Ms. Badenoch, that there were actually no GRT targeted initiatives such as pop-up clinics or bespoke community engagement in respect of travellers?
Well, I know that the Department for Communities and Local Government certainly designed the programme with the Gypsy Roma and Traveller community in mind. And we had data that came back and explaining what was going on and what was taking place. So my understanding is that there were activities. I also know that of all of the groups that we were trying to reach, that was the most difficult. Group. So it might be more of a factor related to that than that no work was done.
Are you able to say why you consider that was the most difficult group, Ms. Badenoch?
If I was, it would be from my experiences, not as a minister, but as a constituency MP who does have Gypsy Roma Traveller communities. There is a significant level of hostility to any state body. Well, even on the education side, visiting as a constituency MP, I didn't feel particularly welcome, even though outreach was taking place. And I think that there are many dynamics within GRT, as we refer to it in government, that make the sort of response we can deliver in a pandemic very, very difficult, especially at short notice. You need people who spend a lot of time, probably of that community, who can do this. And if the culture within the community is of one that is to not interact with the state, it just creates, a tension that's very, very difficult to overcome.
Thank you. I have one final question for you. You discussed community champions earlier on in your evidence. And you say in your statement that the community champions scheme allocated £23.75 million in funding 60 councils and was designed to expand work to support those most at risk from COVID-19 and boost vaccine take-up. That's right, isn't it?
Yes.
And Yvonne McNamara, who is the CEO of the Traveller Movement, she gave evidence on the 16th of January, and she said that there's been a historic problem that the GRT traveller ethnicity is not recorded by institutions.
Is not, sorry?
Is not recorded by institutions. And the example that she gave is that GRT are not recorded in the NHS data dictionary. Now, we've been looking at the final quarterly report, and I know that it makes that point, doesn't it? As a consequence of this lack of recording in relation to data, Ms. McNamara said that local authorities just didn't know how many travellers lived in their areas because of this data capture issue. And my question is, do you think, Ms. Badenoch, that the Community Champions scheme was actually unable to boost vaccine take-up by travellers because of this inadequate data capture issue, particularly in England, meaning that GRT people were not sufficiently visible to local communities?
I would be surprised if the level of knowledge in local authorities was that low, purely because, from the experience I have seen over the last 10 years, local authorities know exactly where traveller communities are because everyone around tends to complain and not want them there. They are very, very knowledgeable about where the communities are. How to get into them is trickier. But I am not sure that, just to the question you're asking about data collection,
yes.
I'm not sure that Community Champions was reliant on data in that way. The purpose of Community Champions was that they had the local knowledge, in their heads almost. And it should, if we had all the data, we wouldn't have needed the community champions. So I'm not sure that that's how we would have resolved that particular issue.
Okay, I don't think I have any more questions for you. I'll just ask. No, I don't. Thank you very much.
Thank you.
Thank you very much, Mr. Jacobs. Thank you very much indeed, Ms. Badenoch. I know how much a burden it must be when we keep asking you to come back. If I
It sounds like you were inviting me again.
No, well, I can't make any promises, but I do promise. I can't make any promises we won't ask you back, but I do promise that we'll do our very best to limit any burden upon you. So thank you very much for your help so far.
Thank you. I'm very grateful for that. Thank you so much.
Very well.
Well, that concludes this morning's evidence.
Thank you. I shall return at 20 to 2.
All rise.